Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. Welcome back in another primary snippet. So last time we discussed about the effect of sudden increase in afterload on LV. And this time we're going to dive into venous admixture. So Maddie, can you please describe the venous admixture and the sources contributing to it in an adult? And also, can you please explain the effects of supplemental oxygen on arterial hypoxemia?
So venous admixture is the volume of mixed venous blood which would be required to be added to ideal pulmonary and capillary blood in order to obtain the pulmonary and capillary to arterial PO2 difference. So it's the calculated volume of deoxygenated blood from the venous circulation which seems to have bypassed the lung and not participated in gas exchange. Diagnosing venous admixture therefore requires calculating the AA gradient using the alveolar gas equation. So the alveolar gas equation is the FiO2 minus the barometric pressure minus the partial pressure of water subtracted by the PaCO2 on the respiratory quotient. Venous admixture can then be quantified using the shunt equation. So where the shunt or amount of blood through the shunt on the total amount of blood flow is the oxygen content of pulmonary and capillary blood, which is assumed to be equal to alveolar oxygen content, minus the oxygen content of systemic arterial blood and this is all divided by the oxygen content of pulmonary and capillary blood subtracted by the oxygen content of mixed venous blood. It's easier to look at this in sort of graphic form than to describe it. So if you have a look at the show notes, it will have the contents of the AA gradient and the ideal, like the normal AA gradient, which is thought to be about 5 to 10 millimeters of mercury, but does increase with age. And then the components of the shunt equation. So we think that the normal shunt fraction is up to 5%. And sources of venous admixture, physiological shunts or pathological shunts. So physiological shunts are anatomical, such as from the bronchial veins or the Bessine veins. So the bronchial veins are blood from the deep bronchial veins that drain into the pulmonary veins in the left atrium. And the Bessine veins are a small group of valvulus veins that drain the inner surface of the myocardium directly into the cardiac chambers. Then there's pathological shunts. So these can be intracardiac or intrapulmonary. Intracardiac shunts are things like VSDs, where there's right to left shunting of blood. So as you can imagine, this blood doesn't get oxygenated. Or there's intrapulmonary shunt, and there's true shunts, which has a VQ of 0. So these are areas of lung with absolutely no ventilation. So these are things like pulmonary AVMs. And then there's VQ scatter, which is blood that passes through lung regions where the VQ ratio is less than 1. So this is in a lot of the pathological states that we see in ICU, so with pneumonias, lung tumours, atelectasis. Now, if we then go on to the effects of supplemental oxygen on arterial hypoxemia, we know that arterial hypoxemia is abnormally low concentrations of oxygen in the arterial blood. And there's variable definitions of it. So it's often defined as a PaO2 of less than 60 to 80 millimeters of mercury, depending on the source that you see. And supplemental oxygen effect on arterial hypoxemia will depend on the cause of the arterial hypoxemia. So we know that we give oxygen to anyone who's hypoxic, basically, in ICU and in hospital, but the effect of that will be variable depending on the cause of their hypoxia. So it will increase the PAO2 or the ideal alveolar partial pressure of oxygen. And if we look back at the alveolar gas exchange, it's easier to see why, as FiO2 is one of the main components of that alveolar gas exchange. But the effect on the arterial PaO2 will depend on the cause. So if it's due to hypoventilation or a low inspiratory oxygen pressure, then there is actually no impairment of gas exchange and no increase in this venous admixture that we just spoke about. So there's no increase in the AA gradient, and supplemental oxygen will therefore increase the PaO2. So it will increase arterial partial pressure of oxygen. If it's due to VQ mismatch, supplemental oxygen should increase the arterial partial pressure of oxygen as it increases the alveolar partial pressure of oxygen, even in low VQ regions, as some ventilation is still occurring. But this effect will be less than if the hypoxia is just due to hypoventilation or low inspiratory oxygen pressure. If it's due to diffusion limitation, then supplemental oxygen will increase the ideal alveolar oxygen, which will generally increase the arterial partial pressure of oxygen due to the raised driving pressure for diffusion of oxygen into the blood. So we're getting more oxygen in the alveoli, and then hopefully this will result in greater diffusion of oxygen into the arteries and then an increase in the partial pressure of oxygen in the arteries. If it's due to true shunt, which is areas that have a VQ of 0, then increasing FiO2 will not affect the partial pressure of alveolar oxygen within these lung units. The increased FiO2 will increase the partial pressure of oxygen within the alveoli of the ventilated lung units, but the effect of this on the partial pressure of oxygen in the alveoli will diminish as the shunt fraction increases. So this can be illustrated with the ISO shunt diagram, which you can see in the show notes. And you can see in this diagram that as you increase the amount of shunt, that the effect of supplemental oxygen or FiO2 has a diminishing effect on the partial pressure of oxygen within the alveoli. So therefore, it is important to consider the cause of the hypoxia in a patient, and this will give you some idea of the effect of supplemental oxygen and the magnitude of effect of supplemental oxygen on the partial pressure of oxygen within the patient's arterial blood.
Thanks, Maddie. So this question need a little bit more conceptual understanding of shunt, and examiners are expecting you to describe that in detail. The ISO shunt diagram is not available in every respiratory textbooks. Probably NUNS is probably the best textbook to find a diagram and explanation about the ISO shunt diagram. So reading a couple of books to gather your information is the key for this question. So sometimes relying on one textbook can be quite challenging to write answers for the questions like this. So thanks, Maddie. Thanks again for the comprehensive answer. We'll be back with another primary snippet in another week's time. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.